So, Assalamu alaikum wa rahmatullahi wa barakatuh. I'm delighted and honor great all distinguished guests and delegates to the second chapter of MENASO Education Academy Cerebrovascular Grand Round 2020, which is organized by MENA Stroke Organization with endorsement by the WSO and AHA. Today, we will have many speakers updating us about the condition of stroke system within the MENA region. I'm so honored that my co-chair will be Dr. Alessandro Firuzi. He's the head of Neurology Department at Medical Clinic City Hospital in Dubai. Dr. Alessandro did his training in Italy, where he got his degree of medicine, then neurology. At the same time, he has been trained as a neurosynology with an extraordinary expert in ultrasound Doppler, extracranial and intracranial. He is one of the few people in the GCC country who's doing TCD. He has a huge experience in adult neurology, cerebrovascular disease, MS, brain tumor, and other disorder in CNS. His primary focus on cerebrovascular, and I'm so honored to say that the first 2 unit, which is established outside the US, accredited by the AHA, has been one of them run and directed by Dr. Alessandro. The other one is by Dr. Maria Khan at Rashid Hospital, who's going to be one of our speakers. No further delay, the time is running, so I will give the mic to Dr. Alessandro. Welcome, doctor.
Dear Dr. Suhail, thank you for your beautiful words and introduction. And I'm very honored and pleased to be here under the flag of the MENA Stroke Organization and the American Stroke Association, American Heart Association, the MENASO, to be able to introduce our distinguished guests and speakers and delegates about this MENASO Education Academy Cerebrovascular Grand Round 2022. So without any further ado, let me introduce the first speaker, Mr. Khaled Skyer, who will give us an overview on stroke center certification. Mr. Khaled Skyer is the lead of Stroke Center Certification Program and Program Manager for the Emergency Cardiovascular Care at the American Heart Association, Middle East and North Africa for the MENA region. He graduated from nursing school in Syria in 2004. He assisted in launching the Stroke Center Certification in the MENA region as a program. And Mr. Khalid pre-AHA experience includes ambulance nurse, paramedic in the UAE, and emergency doctors, ICU nurse from Syria. He's got more than 12 years of experience as AHA instructor and faculty and service manager life support training for a healthcare group in UAE. Please, Mr. Khaled, the stage is yours.
Good afternoon, everyone. I am Khaled Skyer, the lead for Stroke Center Certification with the American Heart Association. I'm going to give you today a high-level overview about the stroke certification journey. Let's start by discussing how we can strengthen the stroke care delivery. Transforming stroke care requires focused effort in connecting all the components of acute stroke care into a smoothly integrated system that reinforces the use of evidence-based guidelines, measures performance, identifies gaps, and engages in improvement projects at a system level. Definitely, that starts with community awareness to identify stroke, early EMS activation, and continues through the hospital treatment to discharge, in addition to rehabilitation and initiation of secondary prevention. This brings together hospital, EMS, regulatory bodies, insurance companies, and all to shape the proactive stroke system of care that saves and improves more lives. So in this slide, you can see the impact of our work, and I'll be highlighting the key milestone in the stroke care journey. As you can see, American Stroke Association was formed in 1998, and in 2003, we launched the Get to the Guidelines Stroke, and 90 hospitals participated in that registry at that time. Today, we have more than 2,200 hospitals caring for more than 80% of all ischemic stroke patients participate in the program. In 2010, stroke program was launched to support hospitals in reducing the time it takes them to treat ischemic stroke patient with IVTBA. In 2013, American Stroke Association launched its Together to End Stroke initiative to raise awareness that stroke is preventable, treatable, and beatable. We also launched our first campaign with the AD Council using the FAST acronym to increase public awareness and knowledge of stroke warning sign and the importance of calling the emergency number as early as possible. In 2015, American Heart Association, American Stroke Association released the focused guidelines recommending the use of mechanical thrombectomy for the treatment of patients with large vessel ischemic stroke. So as you can see in the slide here, the different options of certification in the United States, we offer 4 levels of certification, starting with acute stroke ready hospital certification and ending with comprehensive stroke center. And we brought to the MENA region 2 levels, the primary stroke center and comprehensive stroke center. As of September 2021, there are 1,971 American Stroke Association certified stroke centers. Majority definitely will be like the primary with more than 1,500 and around 227 comprehensive stroke centers. Now let's talk a little bit about the MENA and specifically here in this press release about the UAE. According to this article, which was published in October 2019, every 30 minutes, a stroke patient is either disabled or suffer from a stroke in the UAE, which emphasize the importance and the need for the implementation of stroke prevention and treatment processes so that lives for stroke patient can be saved and permanent disability can be reduced. And as per Dr. Suhail Rokon, the president of MENA Stroke Organization, who said in this article that having such certified centers will decrease the mortality rate, the complication, and most importantly, improve the outcome of stroke. Therefore, early in 2020, American Heart Association and American Stroke Association and MENA Stroke Organization, called MENASO, have entered into a collaboration to work together to advance access and treatment for stroke patients by certifying the hospitals that really can demonstrate compliance by meeting the international standards of care for stroke patients. Both organizations share the belief that healthcare facility certification has a great potential to improve the assessment, diagnosis, and treatment of stroke patients. So in this slide, we can see the different ways that the patient might reach one of these certified centers. Either the patient will go to the center itself, primary or comprehensive, or being transported by the ambulance or the EMS services, or being transferred from another facility. The most important thing is to reach to the appropriate facility on time to give the appropriate management and treatment. So now let's spend a few minutes talking about the eligibility criteria. The American Heart Association, American Stroke Association, and MENASO have developed an eligibility checklist for the hospital who are looking to pursue certification, either primary or comprehensive stroke center. So first, having an appropriate infrastructure in place is key in establishing a stroke center. The infrastructure should include an identified stroke unit, identification of appropriate staff, participating in stroke registry, as well as a professional training and education for the entire stroke team. If we talk about the staffing requirement, the hospital must have an identified stroke director, a 24/7 acute stroke team, an interdisciplinary team, as well as option for stroke rehabilitation to ensure that the patient have the most optimal outcome post-hospital discharge. Moreover, a comprehensive stroke center definitely has additional staffing requirement to ensure that there are specialized and trained neuro specialists available 24/7. Furthermore, to be eligible for certification, stroke centers also must meet a minimum volume requirement. However, if the center are not able to meet this requirement, there must be a demonstration of quality or performance improvement activity that measures overall outcome for stroke patient that facility treated. Finally, stroke centers are also required to be able to perform diagnostic technique through specialized imaging, surgical intervention, and 24/7 access to CT and laboratory. In addition to meeting the eligibility criteria, which I have mentioned, hospitals seeking stroke center certification are also required to submit KPIs regularly to the American Heart Association, American Stroke Association. Performance measures provide an indication of the organization's performance to specific measures in relation to outcome. We have listed here in this slide an example of the minimum requirement for the primary stroke center that need to be submitted in a quarterly basis. So here we can see 8 KPIs, starting with the VTA prophylaxis and discharge on statin medication, stroke education, assess for rehabilitation, and so on. So this is the minimum KPIs for the primary stroke center. And this is based on a data-driven model. Once the facility show interest in this program, the process starts by signing the agreement and submission of the documents. The American Heart Association, American Stroke Association, and MENASO strongly believe that data drive quality, and through ongoing data collection, evaluation, and quality improvement activity, our review is established to help hospital achieve and maintain certification status over time. So from where we are going to get these data, from one of these 3 global stroke registry. The first one is Get With The Guidelines Stroke, or if the hospital are participating in rescue or SITS, these both data registry are acceptable as well. To move to the next step, which is the review, which start with the disc review and then virtual review. The disc review to measure compliance to the program standards through data review, interviews, and identification of the best practices, as well as the areas for improvement. Then followed by the virtual review, which is a meeting that is scheduled after the disc review and include formal presentation by the acute stroke team, followed by the virtual tour in the facility with staff interviews and discussion by the reviewer team. This effort is to support definitely the hospital in their journey to achieve stroke certification status and improve stroke care together globally. Participating facility definitely will have access to a variety of professional tools and educational resources for both healthcare provider as well as patient and caregiver. To conclude, the stroke center care paradigm ensures that patient will receive the proper level of care in each case. Both primary and comprehensive stroke center are essential component of a stroke system of care, which will promote a flexible system that can adapt and fit a variety of regional and geographic scenarios. And lastly, improved outcome definitely will reduce the financial burden on government and healthcare systems. Thank you very much, and we'll be waiting for your questions in the Q&A session. Thank you.
Dear Mr. Khaled, thank you for the crystal clear overview through the journey of the stroke center certification process. Let me now introduce the second speaker for this night. Dr. Mohammed Ayesh Al-Joani is an Associate Medical Director of the Specialized Centers and Director of the Neuroscience Center. Just 1 second, my connection seems to be a little bit sketchy. Now it's working. A director of the Neuroscience Center at KSAMC Madinah, Kingdom of Saudi Arabia, and consultant neurologist, subspecialty vascular neurologist at King Salman Medical City at Medina in Saudi Arabia. He's also the stroke service line lead at the Medina Health Cluster, director of the Neuroscience Center at KSAMC, vice president of Saudi Stroke Society, and a member of the National Stroke Registry in Saudi Arabia. He teaches postgraduate and undergraduate medical students. Dr. Mohammed is a member of several committees and shared in many clinical researches and publications. So without any further ado, let me leave the stage to Dr. Mohammed in his lecture, Stroke System of Care in KSA.
Thank you, Dr. Alessandro. Is the sound is okay?
Perfect.
Yes, doctor.
Yeah. So I might actually dim the video just to make sure that you receive the sound nicely. So I'll be talking about stroke system, and stroke system in KSA. It has these some of just the disclosures that some slides were borrowed from Dr. Fahmy Sinani, our former lead, and he's actually the model of care lead now in Saudi. We know that stroke care is fragmented, and it goes from primary health care to AMS, emergency, neuro ward, rehab, home health care. It's not patient-centered, and mainly it's around hospital or MD. There is a new model of care in Saudi where we actually look into different care like urgent, chronic, safe birth, keep well, late phase, and looking at primary. And it's not now focusing only in specialized hospital. Look at the community and we go further from that. To do that, you need to establish networks. And to establish networks, you need to co-build with the patient, build it around the patient need, and focus on quality. So better outcomes, better experience, and less cost. This is clear now that this is the century of system. It's not the century of hospital. Stroke is complicated and complex. So complexity can be managed not by focusing on small and smaller elements of healthcare, but looking at the problem as a whole and the relationship between these elements. There was a project started about now 3 or 4 years ago, where we actually designed our first project. We looked into, we had values where patient come first, equity of access, value-based healthcare, networking of staffing and institution, looking at best clinical practices and praise innovation. You can see in this picture actually that the patients themselves were a part of the planning process. And we came up with a very nice document, that Saudi Stroke Standards Pathway, where we have KPIs to measures. We have high priority KPIs, which you could look, one of them is looking at median time interval from door to physicians. And we have a benchmarking, what is minimum acceptable or what is achievable and what is excellent. And we have a hospital classification, which is not far from traditional international classification of hospitals, like what presented by Mr. Khaled. We have comprehensive stroke hospital, primary stroke hospital, acute ready hospital, and what are the services needed to be in these hospitals. To do that, we have to create a tool, which is a readiness assessment tool that the hospital filled to make sure that they are a part of the decision-making process and to know the infrastructure available at these hospitals. There was a committee that was established by Dr. Fahmy, and I was part of it as well, Stroke Implementation Committee in 2019. So we had the clusters all around the kingdom be informed, and these clusters appointed leaders to make sure that the alignment of progress at a national level and to share data, improvement project, challenges, maybe administrative support as well, to enhance communication between the stroke leads. And we have a dashboard we look into, and this dashboard is giving us overview what is being completed and at different stages and different levels. Now this committee has been translated to a national stroke network at Ministry of Health. And I have the honor to share this network and co-shared by Dr. Majid Bakhit. And each stroke lead from each clusters is a part of this committee, a part of this network. And we had a very ambitious plan by our Minister of Health, is a 100-day plan to look into stroke, trauma, and acute coronary syndromes to improve their strategic plan, implementation, and sharing data. We had our first master stroke ICCB, where this will be launched to all. This is already launched to all hospitals and all clusters, where each clusters can customize this to their own areas, but they cannot actually change. This is the minimum stroke ICCB, or integrated clinical pathway, where the patient, you can see either starting point at the hospital, or the patient being walking into the emergency, and where this patient should go. And we actually looked into some process KPI and outcome KPI to look into and to report through data collectors and through leads. And this is what we have every week. We meet and we make sure that there is alignment for what we are doing. Some meetings might occur monthly, or some meetings might occur in weekly, sometimes one-to-one, to make sure what has been done and what is being happening all around the kingdom from different clusters. This is an example. Not all hospitals are supposed to have a stroke unit. An example, what you have, it can classify you which level of hospitals that you could have. This is another nice work by our colleague, led by Dr. Saeed, and I'm honored to be part of it as well. This is the virtual medical center, and it is aligned with the Digital Health Excellence Center. They are providing telehealth services, along as governance and regulation for these services. You can see that there is teleradiology, telestroke, psychiatry, pathology, ICU, and a lot of services that being provided through telemedicine. We have our own governance for this. We have a governance framework for the virtual hospital telestroke services, which we actually already included 5 hospitals for the time being beyond the proof of concept phase. And we have not only this, we have a telestroke business continuity plan to make sure that everything in order. This is the virtual medical center proof of concept. We did a final report, and from that report, we received approval to launch this at a national level. We have another service, which most of our colleagues might not know. We have a hotline for neurology. So if you have a patient that have a stroke, we could provide you to allocate this for the nearest thrombectomy or thrombolysis centers, with bypassing all what is needed from faxes and referrals. And these are the things that were discussed with our colleagues and admin. Do we have a stroke unit? Do we have a neurologist? We don't have an interventionist. We don't have more patient. Our hospital already crowded. So we answer these questions nicely. And I have to say, this is not our, it's not an effort only of Ministry of Health. We have the military medical services, the National Guard, the health holding company, the Saudi Health Council leading the regulation part as well. And the National Stroke Registry is coming through the Saudi Health Council. The Council of Health Insurance aligning the telestroke and payments for the buyers, and the Ministry of Health as well. And this is not an effort by one person. As always said, to do this, we have to reach to our colleagues, speak to them. This is the name of most of my colleagues that actually helped me to start our program in Medina, then to go national. And this is the, I will be receiving question at the end of the lecture, and I hope that I presented a quick view on stroke care and stroke care system in the kingdom.
Dr. Maria Khan Junaidi is a specialist neurologist at Rashid Hospital in Dubai, governmental hospital and comprehensive stroke center. She has graduated from the Aga Khan University Medical College in 2001. And after completing her training in neurology, she went on to do fellowship in vascular neurology and cerebrovascular translational research. She also has a master in epidemiology and biostatistics from the Aga Khan University, where she graduated with high honors. Dr. Maria Khan has over more than 50 published articles in leading international journals and has frequently presented at international and regional conferences her researches and trials. She's participating in ongoing multi-center and cross-sectional studies and has been granted funds for previous research in stroke outcome and stroke prevalence. She is an active member of the MENA Stroke Organization, and in recent years has been working to improve stroke service in the MENA region. Dr. Maria Khan, I will leave the stage to you. Thank you for being here tonight.
Thank you so much for the kind introduction, Dr. Alessandro. So my task today is to give the audience a glimpse into what the actual process of certification looked like for our center. I work at Rashid Hospital, and we are one of the 2 first centers to be accredited by this American Stroke Association and MENA Stroke Association jointly. And the idea is behind presenting our experience, I'm going to present, and then after me, Anki is going to present her experience for the other center that got accredited almost side by side. So they did it first, and then we followed them by a few weeks. I'd like to thank Anki. She was a great support. Her experience helped me in a lot of ways as well. The idea behind our 2 presentations is that the audience today should get an idea of what this certification entails. Khaled has already briefed all of you about the processes that are involved, but this is from, let's say, from the perspective of a neurologist or from the perspective of a hospital, what the accreditation process could look like and what it really means for any particular center to get this sort of an accreditation. So this is a brief outline of what I'm going to talk about. Just I have a few slides on the actual purpose of the certification, because I think it's very important to understand why one should enter into this exercise. And then the actual process I will go over. There are certain domains that should be kept in mind for people who are interested in getting this sort of a certification to their own centers. And then we'll go through the final review process that happened at the end. So what is the purpose of a certification? That is something that should be very clear in the minds of anybody who's interested in getting their center certified. Certification or accreditation is a process whereby an external body evaluates your stroke program in terms of evidence-based care that you're providing to your patients. And there are a number of bodies that are out there, mainly in North America and Europe, that are providing this service of evaluation and certification. Their main focus, of course, is their own countries. So as Khaled presented, there are more than 2,000 centers in the US where this certification process is ongoing. But some of these centers, some of these bodies have started to expand into other regions of the world. And the big advantage of this expansion is that they're now bringing the same standards of care globally. So a little bit about this AHA and MENASO certification process. So it was in July 2020 that MENASO and the American Stroke Association set up a collaboration to get the hospitals certified in the MENA region. Now, what is unique about these 2 organizations? Well, they're positioned in a way that they can have shared expertise. So you have experts from MENASO who are more aware of the ground realities of our region. And then you have expertise that the American Stroke Association is bringing. And both of them can jointly then provide services to improve patient outcomes in our region. The stroke certification model that has been proposed will assist hospitals with a framework and a structure, and will help to manage and deliver high quality care by standardizing and increasing the quality and access of acute care for patients who suffer from stroke. Now, the question that anybody who's interested in certification should ask is, why should I pursue AHA-ASA certification or any certification for that matter? So the one purpose of a certification is that it improves the quality of patient care by reducing variation in clinical processes. So there's a standardization that's happening across the systems, and I will show you this various systems that the accreditation process will take you through. It provides a benchmark for quality of stroke management. It provides you an objective assessment of clinical excellence. It creates a cohesive clinical team. So you come together for an accreditation and your team kind of works in cohesion, and that really improves the quality of service. It promotes a culture of excellence in the organization. So there's a drive to do better every time. A center gets certified, there's a competition that gets generated in the market, and it facilitates marketing, contracting, and reimbursement processes as well, which is I'm a government entity, but Anki will tell you more about it. It has that advantage as well from the perspective of private organizations. And then, of course, there's a hospital that is certified will definitely have community confidence. So it's important from that perspective also to pursue this sort of a certification. Now, starting off with the process itself. Now, I'll take you step by step through the things that are required for this sort of a certification to happen. The first thing that anybody who's interested in getting a certification should do is define your team members. You need to know who are the people who are part of your stroke team and who will be working towards this accreditation, because a lot of work needs to be put in. So it is better that the team members and the people who are going to put in that effort are clearly identified at the beginning of a process. The next step is that you need to decide whether you want to become certified as a primary or a comprehensive stroke center. So the eligibility criteria are different. I think Khaled briefly alluded to this in the beginning. I will also talk about it in a future slide briefly also. Once you have taken that decision, you should register your organization on the quality and certification tool. And Khaled and his other colleagues here are always very helpful to facilitate these processes. Then you need to start gathering and uploading documents. So what are these documents? These are documents that you have to provide as evidence of the processes that are taking place in your hospital. So you want to show that you have a coherent, smooth running stroke service right from the time that the patient, there's a stroke code alerted in the field to the time the patient gets discharged and to a rehab service from your hospital. So this entire process you need to show to the reviewers, and you need to provide documents to sort of support each process that's happening in the hospital. Then you have to present data. So some data needs to be uploaded onto this QCT website. What is that data? There are about, if you're going for a primary stroke center, there are about 9 key performance indicators that so for example, if you admitted, let's say 150 stroke patients in a year. So for at least 1 quarter worth of data, you need to collect, and you need to show those key performance indicators where you are in terms of your performance. For a comprehensive center, they are about 17 with some optional ones in addition to that. So depending on what kind of certification you are going for, that will determine the kind of data that you need to upload. Now, there are platforms there are 2 or 3 platforms that you can use for this sort of data entry, which can be helpful to you in future as well. So SITS is one kind of registry that the AHA, ASA is working with to sort of extract this sort of data. There is Get With the Guidelines, which comes with the accreditation process. So you could end up entering your data directly on this platform, and then the key performance indicators are directly extracted and you don't have to do any sort of extra work. Then comes the document review process. There are a few, so our reviewers, usually 3 or 4 reviewers will be going through the documents that have been uploaded, and any additional documents that are required will then be asked for. Then the program review process starts, and this for us was a virtual review, and I believe it is going to be virtual for some time till at least the COVID situation improves. So in these virtual reviews, there are 3 or 4 meetings that take place, which are virtual meetings where your team gets introduced to the reviewers, and they ask certain pertinent questions to better understand your program. You may take them around the various areas in your hospital to show them the actual process. which is the virtual tour of your facility, and then the certification itself. At the end of the certification process, there's a final report and action steps that are given with a deadline to sort of better, to improve your program. Certain weak areas are identified, and these reports are extremely helpful in bringing more quality to your existing program. Now, this is, I think, what I was talking about. So you need to decide whether you want to get certified as a primary stroke center or a comprehensive stroke center. If you are thrombolizing actively 10 stroke cases and you have a basic registry, you have a stroke unit in your hospital, you have staffing available, you have a 24/7 acute stroke team, and you have an interdisciplinary team, a rehab team, then you can apply for a primary stroke center certification. If in addition you have advanced intervention technologies, and you have a full-time neurosurgeon available for hemorrhage management, also for decompressive craniectomies and things like that, then you qualify as a comprehensive stroke center. And the number of cases that you need to treat are different. So we can share these program requirements with you if you are interested, and you can decide which stroke center certification is most appropriate for your center. Once you have taken that decision, you need to go onto this website, get yourself registered for the process. These are the 6 domains that I was talking about, and I'll take you through them one by one very briefly. So first, you need to show through your documents what your program management looks like. So, and the oversight of a stroke program should be done by an interprofessional committee that should have representation from various disciplines, including physiotherapy, occupational therapy, nutritionists, of course, your main teams of neurologists and neurosurgeons, and if you have an internist taking care of stroke patients, that person, radiologist, your interventional radiologist. So an interprofessional committee needs to, you need to show that you have this sort of a committee existent in your hospital. You should have a stroke program director under whom all of these people will have their clearly defined roles, and you should have some frequency of IPC meetings where you're getting together to improve the stroke program periodically. The second pillar for this certification is, what are you doing to educate your staff? So you need to show what kind of education policy is in place at your center. What are the identified staff that you are giving this education to? What are their CME requirements? How are you documenting their compliance to education? Is there a way to evaluate them? What is the content of this education? And then how are you measuring these outcomes, and what are you doing then to bring about an improvement? All of this can be submitted in document form. You can show the meetings that are taking place, attendance sheets can be submitted, and what is the frequency or plans of education that you might have at your center. The third aspect is education of patients and caregivers. So what kind of educational plan is there? What are the touch points? At what points in time do you educate your patients, and how is that thing documented? A very important component for this is discharge planning and post-discharge follow-up. So how are you facilitating this aspect of education? And then how is your stroke, if you're a comprehensive stroke center, for example, how is your stroke center involved in public education? How are you contributing to the community at large? And then another important aspect that you need to show to the reviewers is the care coordination. So we know that the stroke chain of survival has several rungs in it, right from the time the EMS picks up a patient in the field to the time that a patient comes to the hospital, gets an acute therapy, gets admitted to the hospital, and then gets discharged. So you need to show that there's a very smooth care coordinated care that's taking place, and you need to show how this care is coordinated. So what are the referral protocols? How are patients transferred from one location to another location? How is their care endorsed? And then the post-discharge follow-up, how that is streamlined. Then, of course, you need to show the clinical management. So you need to show the CPGs that you might have, which are basically clinical pathways and guidelines that you have in place at your own hospital, and how frequently are they reviewed and updated, and how are people educated about these pathways. It's very important to have a stroke pathway. Anybody who's running a stroke center would understand the importance of a stroke pathway and order sets. You need to show to the reviewer how these are being implemented. And then, of course, every center must strive for quality improvement. So do you have a quality improvement program in place? If you don't, what are your aims about bringing about quality improvement programs? If you're collecting KPIs, for example, key performance indicators, how are they being communicated to the team at large? And then, how is the data to support the performance? Of course, you have to enter onto the system. So here are just snapshots from what your dashboard will look like. And there is an area where you can upload your data. So you have to show them numbers about the key performance indicators that I mentioned. And then you have a document submission area where you will basically, for all measures, you have to upload separate documents in support of that measure, how your hospital is performing that. And this is just a screenshot from where the document is uploaded. Now, I'll just take 2 slides to show you what our journey actually looked like. Our journey is a very old journey, and people who are regulars and have heard me or Dr. Suhail before would be familiar with this slide. Our journey started way back in 2011, 2012, when we first started stroke awareness in Rashid Hospital. We set up our stroke team. Our clinical pathway guidelines were there since that time. And we had also become part of registries, and we had been doing a lot of this stuff from before. Okay, we've had one certification before with the German Stroke Center in 2014. We were at that time also the first center outside the European Union to get an external certification. And then more recently, we got the diamond status last year. So this is where we were when we decided to go for this AHA MENASO certification. So a lot of our work had thankfully already been done, but what we needed to do is to show people how these processes are taking place. So for us, the actual process only took 3 months. So if any center is anywhere near here, they have CPG in place, they have setups in place, they have pathways in place, they have some sort of a registry ongoing, then maybe you're already ready. And you just need to get your team together. And it took me 3 months to get this done. We started in October, started with rigorous data collection because we were collecting certain KPIs. The KPIs that are required for this certification are more in number. So we needed to basically increase the amount of data that we were collecting. So that process started early October. We applied for the accreditation, we identified our team members, and then we started to gather our documents, engaging the teams, and started to upload our documents. The review process started as soon as we had uploaded our document. I'm very thankful to Mr. Khaled. He was very helpful throughout the process. He kept guiding us on and notifying the reviewers also whenever we would upload new documents. Our documents were reviewed. We were receiving almost, very prompt feedbacks on any additional document that might be required so that we could continue to work on those things. Our virtual reviews started after mid-November. There were, I think, 4 in all. And in early December, we had, we were done on the 10th of December with all of our virtual reviews. So that's exactly how long it took us to gather all of this information. So if you're a center who's already collecting all of this and already have a system in place, this is how long it should take you to get a comprehensive, or even a primary would be even easier, stroke center certification. These are just a snapshot from our own experience. these are all the team members, well, not all, but most of them. We have our radiology colleagues, intervention colleagues, our brilliant stroke nurses, our emergency staff who were so excellent in all of those reviews. And then, of course, our multidisciplinary team with our therapists, physiotherapists, our occupational therapists, nutritionists, case management, our quality coordinators, all of those people. So I'm really thankful to all of them. I think this is all of our achievement. So what are the takeaways from the exercise for us? Well, we got the opportunity to recognize our people and their work. I think that is something that we clearly achieved. Our systems, we believe, are more streamlined. We know where our loopholes are. The final report that was sent to us, I believe, is an opportunity to improve our systems. We have greater team spirit now. We think we connect with each other much more easily now. And our team is quite motivated to maintain standards. Our next review is up, I think, in a couple of months, where we need to just answer the queries that were raised in the final report. And I think, inshallah, we'll be very much ready to face that also. So I thank you for your time, and thank you for the opportunity for letting me present here.
Thank you, Dr. Maria. Thank you for a nice presentation. Always I will say, Alessandro, it's nice to hear from Maria. She make everything to look so beauty and simple to be done.
So easy.
So easy. Yes, that's Maria way. She's so smart and good in doing this. Very nice. The message is very clear. To get these type of highly credited type of accreditation by the AHA and MENASO, it's not impossible. There's more than 2,000 stroke centers within the US getting this certification. It's nice to build a good stroke service, but there's always something that you need to improve, you need to do, and that's what Dr. Mohammed Al-Juhani and others are doing. I would like to introduce our next speaker. We will come to Dr. Farah at the end because the topic is just to continue with the same. I would like to introduce Ms. Anki Siraris. Anki is currently working as Centers Program Manager at MedClinic Middle East, Dubai, UAE. She completed her master's degree at Health Care Policy, Innovation and Management from University of Zurich. She also worked as a senior advisor to the to the board directors of Netherlands Cancer Institute. She completed many numbers of courses related to project management, leadership, and personal developmental program. I'm so happy that I work with Anki. I learned few things from her. She's an excellent leader and she's an achievable lady. She knows what she's doing and she's achieving this. Welcome, Anki. Please, you can start.
Thank you very much, Dr. Sahil, for this wonderful introduction. I just want to know if I need to share my own screen. I think so, right?
Yes, sir. You need to share. Click on the share screen from the bottom belt.
Okay.
Yeah. Then it will ask you to override. Just click on yes. Yes, it's visible now.
Yes, you can see my presentation. Perfect.
Yes.
So good evening, everyone. And thank you very much for the wonderful introduction. Thank you as well, Maria, for your explanation of the whole process of the certification process for becoming a primary or comprehensive stroke center. I will share some experience from Mediclinic City Hospital to make sure that everyone has a bit of an in-depth understanding of what it is to start the process and what it is to achieve it at the end. There are maybe some small duplications in what Maria is telling and what my presentation will enhance, but I think from a personal experience perspective, there are always many stories to tell. So I will tell a bit about the journey, how Mediclinic City Hospital became a stroke center. I will tell about the start of the certification process, how we got in touch with the American Stroke Association and the MENASO team, the submissions of the documents. I will tell a bit more about the data collection part, and of course I will give you some insight as well from our side.
Sorry, Ms. Ange, to interrupt. Can you please make the slides full screen?
Oh,
in the bottom. Yeah, thank you.
Yes, okay, perfect. So the development of the stroke center, if it comes to City Hospital, we started as well early on in 2016 with the stroke program within the hospital. And of course, in the beginning, it starts small to see who are the doctors involved, what is the pathway, and what is the scope of a stroke center, and how do you set up a stroke unit. In the coming years, we decided to get a more formal structure, and that's what we call an organizational structure, to see who will be the clinical leads and who will be the head of departments that are included in getting this process on the agenda, and to make sure that that all decisions are made to get a smooth pathway. We are certified, 2018 certified as a stroke center, the same as Rashid. So you can see there's a lot of collaboration already since years by the German stroke certification body. And after that, we were evaluating the pathways to make sure that every time you look at the guidelines, international guidelines, to make sure you are up to date. Staff educational plan. So not only having 1 or 2 educational sessions a year, but make sure there's a structural educational plan for nurses and for doctors within the hospital. And in 2020, we decided as well to start our collaboration with the AHA MENASO to look at what is the comprehensive stroke accreditation about, and are we ready already or not. So I think it was in 2021, I don't know the exact date, but I think it was somewhere in April that we decided to not to only to put the application in, but to make sure that we plan already the dates so we could prepare ourselves for the accreditation that at the end took place in October 2021. It was an amazing journey. So we started, if you look at the clinical practice guidelines, it was something Maria already touched as well. I believe from the perspective of a center program manager, that where you need to start is with the clinical practice guidelines. So this is an example of the document that we have in City Hospital. It is not about the governance, it's not about how you manage the resources and everything, but it's about how you clinically agree within the team how you want to treat the patients. What is evidence-based? What is there on the American Heart Association website? What is well known by all the neurologists and the neurosurgeons? And what do you need to put in place to make sure you have an agreed pathway from a clinical perspective? So we had stroke care based on evidence-based clinical practice, and we reviewed it. We are going to review it yearly to stay up to date, and of course, if needed in between. We are monitoring the compliance of the clinical practice guidelines, and we do that via internal documentation audits. And all the pathways and the protocols that we developed are based, of course, on the international guidelines. Another part is the staff education. You can see different pictures here of the team within Mediclinic City Hospital. We have an annual stroke workshop, 4 hours clinical education and 4 hours education regarding to the rehabilitation part, to make sure that all the nurses annually have a refresher if it comes to the clinical guidelines, to what is the evidence-based practice, what are the updates, and so they can also discuss cases amongst each other. We have an NAHS training that is given by Dr. Alessandro annually to the hospitalists and to the doctors. We have certified ICU nurses for the NHS course. And we also are part of the stroke simulation by the ANGELS simulation program. And this all is to make sure that you keep staff motivated. And what I said already, that you make sure you keep them skilled and you keep them educated based on the most recent practice guidelines. So the start of the certification process, and with the certification process, of course, I mean here the one for AHA MENASO. We started with some introduction calls to understand the process and the criteria. You can see the criteria on a screen. You can read the guidelines, but still it's good to understand in a bit more in depth what is it that is required from a hospital. And also for us, it was a good opportunity to understand the process a bit more. We reviewed the standards and the requirement with the core team, and the core team is the multidisciplinary team where every department is represented, to make sure everyone understood what are the standards, and are we already in line with the standards or not. Very important, as also an advice from my side, is start with the things that you're already good at. So what are the standards that you meet already? And then you can see that probably you will meet a lot of standards, looking at your own stroke unit. And of course, then define the gaps based on the standards and the requirements to see what needs to be done towards a final review process. For us, I think a very important one is to make sure that you invest in education of staff, not only clinically, but also regarding the program, to make sure that it's not only a core team or a center program manager or a clinical lead that works towards an accreditation, but that the whole team understands what is the process that we are going to have in the next 6 months or 3 months or a year. So you get also engagement from their side. And I was very surprised with a lot of ideas that came up from nurses and other staff, because they knew we were busy with this process. They were also already thinking themselves, what can be maybe improved, or what are the things that we can change within the organization. The other insight is to have regular internal meetings or webinars, or what is the best way to have that internally, to present where you stand in the certification process. So everyone will be engaged here in this process as well. And the submissions of the documents, this is already highlighted as well by Maria, so I will not take very long to go through this. Collect and review all the relevant documents that you have, and make sure you have a sign-off from everyone within the team. There you need to think about, have a defined scope of service, what is included, what is excluded in the pathways, your guidelines, your committee charter, and all those kind of things. And advice personally from my side, I thought everyone had to be perfect before we submitted the document. So I was waiting and waiting and waiting before we submitted it. And at the end, Khaled as well and the AHA, they were asking me, when are you going to upload the documents, Anke? When are you going to upload the documents? And at the end, I just did it also with some of the documents that maybe were not ready, or at least with the part that was ready. And I was surprised by all the advice that we got from the team, from MENASO AHA team, regarding the documents. So my advice is start as soon as you can uploading the documents, so the review team can give you very valuable feedback based on what you already have, and don't wait until you think it's perfect. There's always some feedback that you can receive and can help you forward. The portal, as Maria showed you, is a very, very friendly and intuitive portal. It's super easy to submit your documents, and it's also very good. You can have a description per document where you can explain a bit more what the rationale is of the document that you are putting on the QCT portal. Number your documents, that's an advice from my side as well. If you have your own shared folder, then already number all your documents in line with the standards, so it's easy to upload and you are not losing track. And don't use any punctuations or special characters, because then the system will not take it. So please leave that out. Then the review committee will review all the documents, and they will give you feedback before the actual document review process will start. I will leave this is already done. Then data collection and a database. From my perspective, data is the fundament for a stroke program. You have to make sure you can say that you perform very well, perform above target, or you feel your stroke unit is up and running 100%. But the only way to prove it for yourself internally and externally is to have data, to make sure that you see if you are compliant with the standards, compliant with your own protocols, compliant with the international guidelines, and compliant with the KPIs. and there's always room for improvement. And once you start collecting your data and reviewing your data, then also your team will be quite engaged to look at any opportunity for improvement. Define also the process for how do you collect the data, how do you validate the data, and how do you present the outcome. It is not only thinking about an Excel sheet where all the data will be in, but also how do you fill that Excel sheet? Where is the data coming from? And let it be validated by the doctors as well to make sure you're using the correct data. I think it's most important for the KPIs, at least, to make sure upfront that you clarify definitions, the numerator, denominator, to make sure that you start with correct data from the beginning. We had some questions later on about the numerator and denominators, and later on we had to change slightly some of our KPIs to make sure that we were in line with the definitions. So make sure from the beginning that's clear, so you don't have to do that again. If it comes to the database, this is also already mentioned. You have to get with the guidelines, which is for data collection. It's from the AHA, where there's also a dashboard, and you can benchmark yourself against other hospitals and other regions. We are using the SITSMOST database, which is connected to the Get With The Guidelines. And I'm very, very happy to hear or to say that there's a connection, because the SITSMOST is also a wonderful database for clinical research for stroke. And then there's also a European Stroke Organization registry, which is the RESCUE, and you can use those. And they are all supported by this program. So here, the data submission, I think Maria already explained that. You have in the tool, and it's also very simple, you have the measures, you can click here, then you select in which quarter you are in the year. So now we would be in 2022, Q1, and then this is all blank, and you fill in the different numbers that you collected for yourself. So the final review process, the review process for us was divided into 3 sessions, and that was mainly because of the time difference. We couldn't do everything in the evening, because then if you are going to do a tour through the hospital, then it will be very empty in some parts. So we started with an opening presentation that was done by the management, the clinical lead or the clinical director, and our hospital director and medical director, presenting the background of the program, to make sure that the review committee understands as well what is City Hospital and how is the stroke unit placed within City Hospital. Then we had the next session was a presentation of the KPIs, the key performance indicators, where we showed our data collection process, where we showed as well, you can see that here, this part, how we performed in the last quarters. And of course, what are the initiatives that we took based on the outcome of the KPIs to improve our clinical practice or our operations. And the last one, which I found is the most important one, and the one that is also nicest for the staff and the whole team, is the virtual tour, where you basically follow the patient's journey. So we started in the emergency department with our physicians and nurses over there answering questions. What happens if a stroke patient comes in? It's just a very simple question every time. If a stroke patient enters the hospital, what is it that you do first? How do you do your assessment? How is the emergency doctor involved? How is the radiology department informed? And next step is going to the radiology department. And what you do there? What are your protocols? And how do you make sure you treat the patients as fast as possible? To the cath lab, to the ICU, and so on. The surveyors were very interested to understand our pathways. The questions were nice and were good, and the staff was also very proud afterwards that they were able to present their work. Because I think if you are a nurse or a doctor, one thing that you want to do is to show your hospital and the way that you provide care to the patients. That's what makes you proud. My advice is to do a dry run. with the presentation, but specifically with the virtual tour. If there's a virtual tour, you can see me here with a kind of computer on wheels, a cow. And we did a test before with the IT to understand if the connection is good everywhere. And that would be my advice for other hospitals as well. So that is a small insight of the journey from Mediclinic City Hospital. And I will stay, of course. I'm happy to take any question later. Thank you.
Thank you, Anki. Beautiful as usual. Nice to hear from you. And we will have the Q&A at the end. Because of the time reason and we are running short, I would like to welcome Dr. Farah Al-Isa to start her presentation about the progressive stroke care in eastern part of Saudi Arabia. Welcome, Dr. Farah.
Thank you again, Dr. Suhail. Sorry for this technical errors, and hopefully now it's ongoing. Okay, so thank you, everyone. I was asked actually to talk about status of the stroke system of care and where I live, which is the Eastern Province, Saudi Arabia, and especially in E1 Health Cluster catchment area. These are my outlines. Some points that we're gonna go through will mention how many cases of a stroke we see annually, the economic burden of stroke care in our region, the accessibility of the stroke service. We're going to talk also about the clinical pathway that we have, the guidelines that we are following in our province. Also, in the second part of the presentation, I will talk about the impact of having standardized stroke management protocols and pathway. And we're going to have the quality measures compared before and after that stroke pathway implementation. Also, in the last part of the presentation, I will share with you our vision within the E1 Health Cluster in the Eastern Province in 2022 to improve stroke care in the region. If you don't know, the Eastern region of Saudi Arabia, it's actually highly populated among the other provinces. In E1 region only, we have around 1,225,000 inhabitants. This is in one catchment area. And also the speed of population aging in the Eastern region is the fastest. It's expected that the youth people proportion will drop in the next 10 years. So if you compare the Saudi Arabia with other developed countries like United States and UK, the incidence and prevalence of a stroke in KSA is relatively lower due to the predominance of the younger population. And also there is a huge disparity in the stroke incidence among Saudi Arabia regions. So as you can see in this table, there is a variability in stroke incidence reported by different studies. And this is possibly due to the non-uniformity distribution of the healthcare services among these. Okay, as you can see in this chart, that the National Stroke Care Development Program is associated with increasing in the functionally independent patient and also decreasing the disability related to the stroke. So developing a program or implementing a stroke pathway is actually also estimated with cost efficacy saving of around 600 million over a decade. So currently in Saudi Arabia, we have around 9 established stroke centers as a comprehensive stroke center providing advanced stroke care, including thrombolysis and mechanical thrombectomy. In 2011, out of 350 hospitals, only 2 hospitals were providing the advanced stroke care. So this is a really remarkable progress of a stroke service and stroke programs among the kingdom. So the current estimated number of neurologists also who are trained and certified for stroke medicine is around 50 neurology consultants. Each year we have around 2 to 4 new graduates from stroke clinical fellowship. And you know, one of the major barriers to implement a stroke pathway, if you have shortage in stroke expertise or lack of stroke expertise in the stroke network. This is a classification system that is, as a national level, we agreed on that proposed by Ministry of Health to classify hospital according to the resources and the services that are available. So the classification allows hospital within the network to divide into acute stroke ready hospitals, which is the minimum level of acute stroke care. Other hospital is primary stroke center, where stroke unit is available, providing thrombolysis and stroke unit availability, and the advanced stroke care, which is the comprehensive stroke centers. So comprehensive stroke hospitals in the last part, located actually in the medium and large size hospitals, able to treat all types of stroke patients. There is significant difference between comprehensive and a primary stroke center in terms of the advanced stroke procedure, which is the mechanical thrombectomy, the advanced neurosurgical procedure, and I'm sure you all know the differences between these classifications. So the designated stroke centers, as Dr. Mohammed mentioned regarding the gap analysis, which was proposed by the Ministry of Health, were able to allocate these centers in the E1 region based on the evidence. Recognizing different level of stroke center is really important. So currently we have 2 comprehensive stroke centers capable to administer minimum of 25 TPA for eligible patient per year, and perform minimum of 15 mechanical thrombectomy per year. Also making sure that the other hospitals, which is the primary stroke center and stroke ready hospital, they have 24/7 CT scanner, CT angiogram, and train the staff to follow the stroke protocol in order to give the acute treatment. These are the mapping that we shared with our EMS team. So you can see the hospital's distances. For example, King Fahd Specialist Hospital, which is one of the comprehensive stroke center, you can see the timing and the distance in kilometers between each primary center and each stroke ready hospital. So this is allow the EMS to transfer the patient to the designated hospital where the stroke care can be provided. So the identifying the stroke center level is really crucial in this step to develop efficient stroke clinical pathway. Recognizing stroke ready hospital is the first step, and afterward improving the service in each of these centers is really important. But we have also the non-stroke ready center, as you can see in this part of the table, where hopefully soon in the upcoming year, to improve the service and to make these centers also stroke ready, where CT is available, and 24/7 also stroke code activation in these centers. So these are the national stroke standards, or the KPIs that Dr. Mohammed mentioned in his presentation. We have around 13 KPIs by the Ministry of Health. We have also priority KPIs, all to measure the efficacy of the stroke protocols and the clinical pathway, and making sure that we are within the international and national standards. These are the priority KPIs that was also determined in the last 2 months as a priority KPI for our master stroke pathway. As you can see, the first KPI is median time interval from door to physician, median time interval from door to CT, median time interval from door to IVTBA bolus, and the proportion of acute stroke patients who are admitted to the stroke unit. And this is our master stroke pathway that was placed by the MOH. This is our actually map to follow in each cluster, and you can customize it, and we try to customize it to our available resources. The number of our centers that we have, and the distance between these centers is also should be considered in this map. So just in the upcoming slides, because I don't have much time, I will just show you the difference and the impact of the stroke pathway implementation in the last 3 years. And this is mainly in our region in the E1 health cluster. You can see here the door to CT time was actually progressed remarkably over the last 3 years. I mean, improved remarkably. The target of the door to CT at 20 minutes was achieved in 2% in 2019, and the latest data analysis was achieved more than 90% after stroke pathway implementation. This is mainly due to stroke code activation, having a dedicated portable bed reserved for stroke patients in the ER, and also the availability of a stroke code team as in-house and immediately assessing the patient in the ER triage or in the CT scanner while the patient ready for the imaging. This is also for the thrombolysis, the IV type TPA rate administration was doubled actually in the last 3 years. This is likely due to unified treatment protocol in both primary centers and comprehensive centers. This is also due to training of the staff from the ED and nurses. It facilitates identifying patients who are eligible for TPA, improving the door to CT time definitely affected the TPA rate administration for the narrow window, which is the 4.5 hours. And we still need to reach the 26%, which is the minimum TPA rate administration by the National Stroke Standard. But we can see the progress in the numbers, and we are aiming for better results. Also, the improvement in the door to needle time, it's reaching less than 30 minutes. This is our median door to needle time in the 2022. Previously, it was even exceeding 30 minutes. And we are hoping, inshallah, for better numbers, but we can see the progress and the improvement and the effect of that clinical pathway in the door to TPA. We also try to figure out what are the reasons we have for the delay in door to needle time in the previous years, in 2019 and 2020, and we went through the records we collected, and we found out that the most common reasons that delayed door to CT time, we solved this issue, as we mentioned before, with the suggested solution. Other reasons for the delay of door to needle time was incorrect triage, so we try to improve the ER staff education and orientation and how to recognize acute stroke symptoms and how to activate stroke code immediately in the ER. Other factors which could be not related to the hospital is patient-related factor like uncontrolled blood pressure and obtaining consent and hesitancy of the family caregiver to give the TPA. And I think educational campaign gonna be the solution for that. Definitely increasing awareness among community will improve getting the treatment for the stroke.
Dr. Farah, 1 minute is left.
Yes. Okay, so mechanical thrombectomy also rate, we found it decreasing. As you can see, this is due to detection of the large vessel occlusion stroke by the CTA protocol became mandatory in every center. When you do brain CT, you have to do CT angiogram for the carotids and the brain. And also the availability of neurointerventionists in the comprehensive stroke center, we are getting higher number. And also the abundance of the experience, accumulating experience will improve the result of the thrombectomy and recanalization. And we are hoping also for getting more cases per year, inshallah, in 2022. Stroke severity, this is also, you can see the improvement. I will just skip a few slides and we get the last slides for the certification and the get with the guidelines. Most of you know the get with the guidelines for stroke from American Heart Association. It's the hospital program to improve stroke care by promoting consistency to adhere to the guidelines. And the program started in 2003. Many hospitals, around 2,000 hospitals entered their patient, and there are many benefits from the Get With The Guidelines program, reaching even international level. For the stroke center certification, the road to stroke center certification, as Dr. Maria mentioned, it's really challenging and requires full integration of the multidisciplinary team in the hospital. Not only neurologists, but nursing, neurocritical, rehab, neurointervention should be hand in hand together to get the certification done. And it's really complex, but it's worth it at the end. And when you feel you are ready, you have the numbers with you, you have the protocols and the pathway. I think it's better to come ahead and submit for the certification. for the Comprehensive Stroke Center and the Primary Stroke Center. The last one is about our future. Just I will end with this slide. We mentioned that we are progressing, and the pathways is really beneficial, and even in the literature is efficient, but also we are ambitious, and we are looking for the future to implement technology along with our progression in knowledge and from the mobile stroke unit using robotic telestroke, and also robotic neurointervention that we heard about it last year, if you remember, from our colleagues in Canada. So really technology is improving our health and improving our care as a care provider in the field. Thank you so much for your time and attention, and thank you for the invitation. I'm really sorry for the initial technical issues, but alhamdulillah.
No worry. Thank you, Dr. Farah. Amazing work, amazing work. So no further delay. We are late by 5 minutes, Dr. Alexandro. So I will ask Akhilesh, if you can put everyone on the screen. We have some panelists who just join us from the US. I would like all of them to be with us. We have Star there from the US, Louise is there, Ron, Julia, and who else is there? Farah and the others. So welcome all of you. Deb is there also. Hi. So more than welcome to be with us today. And we invited our colleagues from the AHA who did the survey of evaluation and guided the 2 centers of the US to be the first 2 centers accredited by the AHA and MENASO. There's many questions from the audience. I will leave the questions Q&A to Dr. Alexander to start. Please, you can start.
Thank you, Dr. Suhail. So I've seen that there are a few questions in the chat box, but also there are some interesting questions for the panel. I will just pick one to begin with from the audience. Dr. Faisal was asking if do you have a stroke criteria or protocol that can be used by the Red Crescent towards stroke patients in order to better encourage patients in a fast-track CT, for example, pathway. If anyone from the panel or the speakers want to step in.
And just as point of clarification, Red Crescent is the emergency services. Is that correct? Yes.
Correct.
Just want to make that point for our team in the US that might have some response.
It's the equivalent of the Red Cross.
Maria, do you want to answer that? Maria Khan?
Sorry, I didn't quite get the question. So what's the question? Can you please repeat that?
I think that they are asking if there is the possibility to have like a commonly shared stroke pathway or stroke criteria that can be used by the Red Crescent to facilitate the referral of the right patient to the right center.
Well, of course, there are many. So one of the key processes is an expedited transfer to a right facility. So, and I mean, I'll talk. I can, of course, from my own experience, I can only talk about my own city, Dubai, where the ambulance service is quite centralized, and we periodically carry out educational programs for our EMS staff to train them in stroke identification. The city is a small enough city where, you know, the hub and spoke or other models of stroke services do not exist. But if we have to talk about the region at large, then, for example, Dr. Farah might be able to, or Dr. Muhammad might be able to talk more about this, where their ambulance services can be trained to identify and direct patients to appropriate services. So, of course, I mean, depending on what stroke model your city follows, for example, there can be standardized procedures that can be developed, and the EMS can easily be trained to sort of triage patients appropriately in that manner. I hope I've answered that question.
Thank you, Dr. Maria. And maybe for Mr. Khaled, is ICU a mandatory point to get accreditation?
Again, please. Is there what, Doctor?
So one of the questions is ICU, so intensive care unit, is it a mandatory point? It's a mandatory structure to get accreditation?
It depends on, thank you very much for this question. It depends on the level the hospital are going for, but as long as they have a dedicated beds within the hospitals and plus a dedicated staff and protocols to follow when they are accepting a stroke patient within that unit, that will be fine.
Thank you, Khaled. And there is another question in the chat box. How long or quick can be evaluated if the patient has a stroke or other similar condition to stroke? No, this is not very clear.
There's one question. How long this process of accreditation will take? Maria said it took for her center 3 months. Anki said 3 months. I would like to hear this from the members in the US, how long the process for accreditation for primary or secondary will take. Star, can you answer that?
Absolutely. It really depends on your hospital's readiness. Like Dr. Maria and Anka mentioned, they were pretty ready, but they did have to do a little bit of work of putting some things on paper and organize some of the documents so we can see them. But it really depends on your readiness. And once you're feel like that you're ready, you have documents that you want us to take a look at, then the MENA team will let us know, and then we'll follow up with you. And then we will work with you and look at every piece of documentation that you have to see if we need to enhance any of those as you move forward with the review process.
Thank you. If I can take the chance to ask also to Deb, what are the data, the minimum required data that need to be collected in preparation for certification, so that also for the audience could be clear what they have to focus on in the beginning?
Yes, thank you. So the data that we collect, there's certain things that inclusion, exclusion criteria, and some things to take a look at is number one, inclusion, exclusion criteria for the TPA patients. So patients only are included if they're within 2 hours of last known well in that measure. So if the patients come in later than that, then they should be excluded. If they're enrolled in a trial, if they're there more than 120 days, if they have a reason that they cannot receive TPA and that's documented, then those patients are excluded. So it's just important to know the inclusion exclusion criteria for that. Another one is the modified Rankin score. So within 90 days of those patients who are treated with IV or mechanical thrombectomy, or IV TPA or mechanical thrombectomy, those patients need a follow-up call, at least a call or a visit or whatever, to obtain a modified Rankin scale score. And that's been a little bit difficult. So just trying to think of ways that you might be able to do that, such as phone calls and those kind of things. You know, we know that a lot of the patients go back home, so it may be difficult, but you know, we can just help you work around that. So those are a couple of the main things that are more difficult for some of the hospitals to obtain.
And we would like to see at least a minimum of 1 quarter's worth of data when you submit your program, so we can follow along with you as you build the program over time, but we'd like to see at least 3 months.
I have a question, Dr. Alexander. Thanks for Diba and Star for Dr. Farah. Farah, you spoke about improvement of your KPIs in the eastern part of Saudi Arabia. How did you achieve that when you said it was 20% of door to needle? Now you are doing around 80% of your goal time. Can you give us three things that you were able to achieve in the eastern part of Saudi Arabia?
Yeah, so as I told you, Doctor, it takes time, and also the data. If you have electronic data registry to connect all these hospitals, and you try to go retrospectively what's wrong and what is to identify the gap. So when you identify that the patient is not getting the CT on the right time, this is one of the most common reasons that we found out. Patients incorrectly they misdiagnosed in the triage. This is also one of the other common issues that we faced before. So the data will let you know everything. What is the gap and how you can solve it? But you need definitely a time frame to study this data in different circumstances and different hospital levels, and you try to solve it. But you will be surprised when you know the reason.
Interest. Alessandro, it's your turn.
Sure.
Can I add on that quickly? Because I know it is 1 month or 1 quarter, so 3 months of data is the minimum. Just from my experience, I would say try to have a little bit more months, because if you look at the number of stroke patients, if the volume is not, if you don't see 8 stroke patients in a day, then it can also differ why you are not fulfilling the 80% or 85%. Sometimes it can be there was a delay with the CT, the other time it's a delay with transferring the patient internally, the other time it was a delay in the radiology. So to understand your process, sometimes you need a little bit more track record of your data to see where is it recurrent, to make sure that you improve there where it's actually needed.
Thank you for the clarification, Anke. Totally true. And we saw that when we were working in City Hospital for our certification. There was one more question from the audience, and maybe I would ask if Julia can step in answering to this. They were asking what about the challenges with patient and family education in a certified center?
Sure. Obviously, we would really like for stroke centers to collaborate with public health leaders, including their emergency medical service leaders, so that every county knows what emergency number to call when they need to access for stroke treatment. The public education program should include risk factors, who to call, and definitely the stroke warning signs. COVID has obviously caused a barrier to some of our communities in community education, but you are allowed to use digital community education. It's very acceptable. And the American Heart Association and the American Stroke Association offer several stroke awareness programs and educational materials through their website at www.stroke.org. It may be that it's not limited to paper education or going out in the public, but obviously clinical education such as blood pressure management and the barriers, signs and symptoms of stroke.
Interest. Alessandro, if you'll allow me to direct these questions to Ron. Ron, Dr. Maria spoke about the EMS education that we are doing in Dubai or in UAE. What the ideal collaboration from your own experience between the coordination and engagement of the EMS system through the stroke system or stroke service?
Thank you for that question. So what we like to see is that true collaboration, as you mentioned. So when the emergency medical services are connecting with the hospital, to have a standard process that they know if they're reporting on a stroke patient, to include things such as what was the blood glucose if it was taken, the last known well time of the patient or the symptom onset, as well as if they performed a stroke scale in the field to determine it was a stroke. And if they also do large vessel occlusion scales, to let the facility know what those scores are, and then clear communication that they're bringing a stroke patient. Sometimes what we hear from EMS is they describe a stroke of different deficits like arm weakness or facial droop, but they don't want to call it a stroke. But by calling it a stroke on the actual report, it helps people heighten their awareness. And then I think the other piece is once the EMS comes into the hospital, to be able to share, if there's no one with the patient, direct contact information for someone that could help make that decision or provide more insight on the patient's care.
There's a question regarding the support that the AHA and MENASO can deliver to any center in Saudi Arabia, UAE, Gulf state, or in the Middle East. What type of support, Khaled, you can give these centers in the process of accreditation?
Thank you very much, Doctor, for this question. So actually what we are doing, we are working from day one with the facility, with the interested facility by doing a consultation, quality consultation, help them understand the standards of the program manual and what are the needed documents as much as we can before we connect them and introduce them to our US reviewer where they start working with them. And previously we have discussed with you, Doctor, as well, the possibility of learning from your experience at Rashid Hospital as well as in Mediclinic. So in the future, we might include these two certified facility in our initial preparation for the hospitals to learn from your experience.
And I would like to ask Alessandro here, from your journey, Alessandro, do you think that Mediclinic City Hospital will be available to support any other center or hospital in UAE, in Saudi Arabia, through Anki, through you, to show them how did you go through this process?
Thank you, Suhail. Absolutely, I would say yes. I think this, for us, it was a learning process. We improved so much. Thank you to this accreditation process. And we would be very happy and available to share our journey with other colleagues and other centers to try to improve the level of care, of stroke care, and to be sure that it becomes a standard, so that everybody will be following the same rules of engagement, the same level of quality and care for the patient's sake, for the quality of the service itself. Absolutely, yes.
Thank you. Before we...
And I can... Oh,
please,
sorry.
go ahead. Is that
I just want to do maybe a suggestion, if that is possible. If you look at the MENASO, but also the review committee of the AHA, you see so many documents passing by in your review of the documents. Maybe it would also be a good idea for this region, because I know the EMS system is different than we use it. Of course, we have a different approach sometimes. If you identify some very good documents, maybe that can be also collected by you to say, this is a good example from every hospital or any hospital, to share that with the hospitals that maybe want to apply. So we don't have to invent the wheel. Besides the fact that we're happy to support other hospitals as well, of course.
Interest. I'm taking that questions about reinventing the wheel to Farah and Mohammed, and ask them one of the last questions. Do you think that there will be a conflict between the local certifying body or the AHA in certifying a stroke service in certain country? In UAE, we thought that having AHA, a well-standard established organization with more than 2,000 stroke centers in the US, with that high caliber, to come to the UAE to do certification within our governmental and private sector, that enhance and build the standard of care that we are willing and we are doing in UAE. Do you think that will have any conflict in a country like Saudi Arabia or others? Farah and Mohammed, as both of you are the leader of stroke in Saudi Arabia. Farah.
Yes, Dr. Suhail, I can answer the question. Actually, definitely, there is no conflict at all. They are aligned together, and the American Heart Association, American Stroke is well-known certification. It will be really an excellent international recognition. Going to improve our standard of care, and we are confident of health maybe coming soon. Actually, after the implementation of the stroke pathway in different regions, not only in the Eastern Province and in Medina, if we have the implementation across the kingdom for the protocols, then I think it will be a really great opportunity for us to have the certification from the American Stroke.
Nice. Mohammed?
Yeah, I will add, sometimes I wear a hat of an admin. So there is an administrative support for local accreditation programs like Sibahi. There are hospitals, accreditation stroke regarding GCI. I think a quick win for AHA is the private sector in Saudi. They are actually have a different budgeting system, which allowed them to engage AHA and so on. And I have to say that, for example, in Medina, there is actually a program, a heart failure program that's accelerated by HA, which is something that we hopefully extended to stroke as well. So there is a big room, there is a collaboration, I think, in the horizon. And as mentioned by Farah, once the people are comfortable with their protocols, comfortable with their programs, the next step will be accelerations, of course.
Okay. There's one question to Dr. Sohail Alessandro. Do you want to direct that questions to me?
Sure. So it's a very hot question, I would say. Is there any plan to extend the pathway for stroke center in Rashid Hospital to cover the care and transfer of patients from other hospitals where stroke management is not available? And of course, we'll be happy to help you answer to this question. If
yes. So thank you for a nice question. It seems that this person is in UAE or in Dubai. We start a program of receiving patients outside DHA, or if I will speak also with the medical clinic, there's patients transfer from different facility, governmental and private, mainly from the North Emirates and Sharjah, where a direct contact between a neurologist in those facilities, and I can mention the names like Al Kuwaiti Hospital, Al Qasimi Hospital, King's Hospitals, many hospitals, private and governmental, in the Northern Emirates within Dubai and Sharjah. They're transferring their patients to these two accredited centers within Dubai. The point that I will advise all the audience, time is very important. If the emergency department receive a patient with acute stroke and the CT was normal and you need to do a quick stroke protocol, please build an MOU or a plan of transferring these patients as soon as possible to one of the two facilities. EMS service has been trained by the neurologist, by Emirates Neurology Society, by Dr. Maria and me over the last 8 years about where to transfer the patients to the right hospital. But certain patients will be presented by their family to the wrong service or emergency, which doesn't have any stroke service, but we are more than open. Can we build a structure where a direct patients will go? I'm working with this with Alessandro, and Alessandro can explain more about our next plan in 2022.
Yes, I will just echo your words, Dr. Sohail. I think this is an amazing project of collaboration between private and public hospitals to provide stroke care. We are open to help anyone as much as possible. And we are working on building a sort of a fast track protocol, collaboration protocol with other hospitals to make this journey of the patient suffering from stroke as quick and as fast and seamless as possible, because we know that time is brain. We don't want to wait and to lose too much time because of bureaucratic issues. So we are working on that, absolutely, yes, together with the friends and colleagues in Rashid, and hopefully also with the DHA help. This will become a reality soon.
Yeah, there's other hospital which is coming soon as a primary certified center in UAE, and they are working close with Khaled and the AHA office in Dubai, and we hope that we'll have more of these primary and comprehensive centers in 2020 in Dubai and UAE. I think we are late by 30 minutes. I would like to thank my co-chair, Professor Alessandro from City Hospital Medical Clinic Dubai. Also, I would like to thank the team from the AHA. I'm so glad to see Louise and the others from the US. I would like to thank Khaled, Anki, Mohammed, Dr. Farah, and Maria Khan for their presentation. It's always delighted to be part of MENASO Grand Round Monthly. All of you are invited. We had a huge number. I will not mention the number here, but it's a huge number of attendees that we had today. All the CME hours will be sent within 2 weeks from today. Please follow the next webinars, which will be from Egypt with interest cases, challenge cases. Then we'll have Saudi Arabia in month of April. Wish you the best, and thanks again to Dr. Alessandro and the team.
Thank you, Sohail. I think tonight really set a milestone in stroke management, trespassing the boundaries of healthcare system differences across regions, for the improvement of the stroke care. We're working all so hard now. We've got a way to prove it and document it.
Louise, do you want to start to say something? Louise, we met in 2000, unmute yourself, 2019, and she led this project. Louise, unmute yourself.
Thank you, Dr. Suhail. So I just want to really echo everybody, the gratitude that we all have for the contribution of all of you to the work that's happening around stroke in the Middle East. It's really important work. We all know that. We always say we're preaching to the choir, but we got to get the word out there. So thank you again. And I just want to reinforce that this process is very collaborative. And I think you heard that from Anki and from Dr. Maria Khan as well. The intention is absolutely to help elevate all of your services, whatever those level of service that you can provide. We're here to just provide guidance and counsel. We've been doing this work for about 20 years. We feel like that experience is valuable, and we really want to share that with all of you. So again, thank you to our HA US-based team, our Middle East-based team, and all of you volunteers and physicians and thought leaders that are really helping to drive this in the region. Very grateful.
Shukran. Thank you.
Shukran.
Thank you.
Bye.
Shukran.
Thank you.
Thank
you all.
Bye.
Thank you, Maria. Thank you, everyone.
Bye.
مع السلامة.
Bye bye. مع السلامة خالد.
Yeah.